Good evening, everyone. My name is Gabriele Colasurdo. I'm the Manager of Education and Patient Services at Myeloma Canada. I'd like to thank everyone for joining us this evening for Myeloma Canada's educational webinar series on the latest myeloma research updates from the ASH 2017 meeting. Our presenter tonight will be Dr. Rayan Kaedbey, who is a hematologist-oncologist at Lakeshore General Hospital in Montreal. Before we get started, I just wanted to let everyone know that this presentation is being recorded. And if you miss anything, don't worry about it, because all of our webinars are recorded and are made available on our YouTube channel, as well as our website. So from YouTube, you go to www.youtube.com and you type in Myeloma Canada in the search bar, and then the first hit you'll see will be Myeloma Canada, and you click on Myeloma Canada and you'll be able to see all of our videos, like so. And for our website, if you go to www.myeloma.ca, and on the bar at the top, if you click on resources, a drop-down panel will open, and you should click on Myeloma Canada educational videos, and this will redirect you to our YouTube channel. At the end of the webinar, you'll have the ability to ask questions or to type your questions in, and I will read them to Dr. Kaedbey. To do so, on your GoToWebinar panel, you have a questions section. And if you type in your section right here where I'm pointing my mouse, and click send, I will receive the questions and I'll be able to read, and click send there, I'll be able to read them out to Dr. Kaedbey. So without further ado, I'm going to pass the microphone to Dr. Kaedbey, who will let us know what the latest myeloma research updates are from the ASH annual meeting. Dr. Kaedbey?
Yes. Hello, everybody. So I hope everyone can hear me well.
I hear you.
Okay, perfect. So I'll start by introducing myself. So thank you, Gabriele, for that great introduction. My name is Dr. Kaedbey. I'm a hematologist who works out of the Royal Victoria Hospital at the McGill University Health Center, and I'm also affiliated to the Lakeshore General Hospital, which is more of a community-type hospital. So I do get to both senses of the different worlds in an academic center and a community center, which is quite relevant when it comes to real-life myeloma treatments, and we'll get into that in some detail right now. And I'd like to also thank Myeloma Canada for having me and giving me the honor to speak to you all. After meeting various physicians that treat myeloma in the US and different countries in Europe, I would just like to start by saying that I think Myeloma Canada is unique in empowering Canadian myeloma patients and arming them with a solid knowledge base, whether it be through different educational sessions or webinars like this. And ultimately, this creates a patient voice that can sometimes be the strongest and most influential tool in advocating for disease awareness, and especially in Canadian politics, I would say drug access. So I encourage you to be involved and to be engaged in your care and ask questions to your treating physicians. These are my conflicts of interest. So I've sat on advisory boards for various pharma companies.
We don't see your slides. We only see the first slide.
Okay, hold on. Let me just see what's going on here.
It doesn't look like it's in presentation mode.
Give me a second. Do you see them now?
I see them, but they're not in presentation mode. I see your notes and...
Okay. Give me a second here. How about now?
No, nothing changed. I think you have to go to the application and select the other PowerPoint, perhaps. There might be two PowerPoints in there on your GoToWebinar.
Okay. Hold on. This is my main screen. Well, I guess if I share my main screen and then...
there you go, that works.
How about now? Is it you see? Do you see everything? Okay, perfect. So this is the outline of the talk. Sorry about that little glitch. So I'll be kind of briefly going through some topics. I feel like I should lay some background out before jumping into what was spoken to at ASH. I suppose there's a lot of people here that are listening that are at various stages of their diagnoses or treatment plans. So, and I'm sure some of you are more well versed with some of the literature and some of you aren't. So I'm just going to set the background with explaining a little bit about myeloma and then jumping into some of the definitions that are used a lot in these big conferences so that when I'm presenting some of the clinical trials, they won't be as daunting. So this is the, just for you to know as background, the epidemiology of multiple myeloma in Canada. So in 2017, there was an estimated 2,900 new cases of multiple myeloma that were diagnosed. This correlates with what we see in the States. So in the States, since the US has about 10 times more the population than Canada, they're also seeing about 30,000 new cases of new myeloma patients in the US in the same time. And the average age at diagnosis is 62 years old for men and 61 for women. It tends to be a little bit more prevalent in men than it is in women. And, you know, myeloma, although not the most common malignancy, given that now people are with our current treatments, the life expectancy of myeloma is growing a lot more. The prevalence, so the actual number of patients with myeloma in Canada, is growing significantly. So just in terms of what myeloma is, so I'm not sure, can they see the mouse, my mouse moving around?
Yes, we see it.
Okay.
We see it, yeah.
So, so in terms of the diagnosis, this is just a little bit of pictorials plus the official definition. So this is a normal bone marrow where these sort of more purplish cells are, in fact, are white blood cells at different levels of maturation in the bone marrow. And here in multiple myeloma, these big bluish type cells that are fluffy with, these are sort of the plasma cells that are, which define what multiple myeloma is. These are the cells that create those proteins that you'll often hear us speak about when we're talking about how you're responding to treatment. With regards to the diagnosis of myeloma, it used to be such that you would have to have these plasma cells in your marrow with a defining myeloma event, which was typically depicted by these 4 elements here, which are referred to as CRAB criteria, referring to calcium, renal, so kidney insufficiency, having anemia, and having bone disease. So a lot of the manifestations of myeloma can present in about 2/3 of patients. They present with some sort of bony problem. And now with the more updated criteria, we also use sort of the number of plasma cells in the bone marrow, the level of the proteins in the blood, specifically the free light chain ratio, and now we're using more imaging such as MRI to better see the bone marrow. And if you have any abnormalities amongst those 3 things, you are also considered to having having active myeloma and would start treatment. With regards to staging, this is a revised international staging system that we use. And again, you know, a big disclaimer here, these are all statistics, and you know, when we talk about medians, it usually means that 50% of people will do better than these numbers and 50% of people will do worse than these numbers. And so it's important to not hang your hat on these numbers, as each of you are unique and may or may not sort of follow the expected path. But this is just for you to have a taste, because I'm sure when you were first diagnosed, this is one of the first questions that came up between you and your doctor. And just for you to sort of understand, we use these set of criteria to define if you're an advanced or a high-risk patient or a low-risk patient. And so these staging systems are based on certain blood tests, and as well as these, what we call cytogenetics, these markers of your myeloma. And we combine all of them together and we can come up with these 3 different stages. And the outcomes are very different for someone who has stage 1, who, you know, the median, so more than 50% of people are still haven't relapsed beyond 7-8 years, and compared to stage 3, where you know, roughly 50% of the people have will have succumbed within around 4 years of their treatment. So these are just numbers that if you were to compare them to 10 years ago, before we had a lot of these newer drugs, they're drastically different. And so the hope is that with all this time that we're buying with our current treatments, that there will be that silver bullet that'll come through and really make the biggest difference for you guys. I won't belabor the response criteria a lot, but I will touch upon minimal residual disease, as you'll see it come up a lot in the clinical trials. Currently, there's many different methods of measuring minimal residual disease. And so when we talk about minimal residual disease, it usually means that, you know, once we have you in what we call a complete remission, where we can no longer detect any of the myeloma in your body, we are now looking at better ways to try and make sure there's not those few leftover cells that are what causes everyone to relapse at some point, as we know that we can't cure myeloma. So we're looking in a lot of the clinical trials to define how to best measure this minimal residual disease, and you do need to be careful on how it's done and how it's applied. And I don't think we know exactly what to do with these results yet, but what we do know is that certainly in all of these big studies, if you've attained these minimal residual disease negativity, so you can't even detect the disease at these very, very minimal levels, it's been associated with an extremely good prognosis over and over again in different studies. It seems as though the method of getting to this state of negativity is not as important as just getting there in general. So it doesn't matter what medications you use. If you can achieve this state, you will do well, generally speaking, in all of these clinical trials. So when we talk about complete remissions, historically, so down here, sorry, they came out quite small on these slides, but when we talk about complete remission, it means that that famous M peak that we talk about every time we see you is sort of the tumor marker that we use in following your particular myeloma. And so when someone's in a complete remission, we really can't identify that peak in any sort of way, including the light chains, which is the sort of another element of that protein that's being produced by the plasma cells. So when someone's in a complete remission, you really can't detect any of those on our conventional blood tests. If you have a very good partial remission, it usually means that the bulk of it is gone. So more than 90% of that protein that was detected has been eliminated. And then you have partial response where it's more than 50%, and so on and so forth. So the deeper the response, so the more the closer you are to having a complete response, or now we're trying to look for MRD, the better the outcomes are in general. And it's important to keep that in mind in general, because we all have patients who remain in sort of a very good partial response for many, many, many years and still do just as good. So there's certainly a lot of parts of this that we are still learning about, and that's why when it comes to this MRD, it's important to just put it all into context. So again, about definitions, and again, before I jump into a lot of these studies, the disclaimer is that you're going to see a lot of numbers fly by, and some of them might look interesting, some of them might look a little bit daunting, but you can't forget that these are statistics. You are all unique patients that may or may not follow the expected path, and you also have to consider that multiple myeloma is really a heterogeneous disease. It's a condition that's very different between patients, within patients, so within yourselves, and it also evolves over time. And so what I mean by that is when it comes to understanding how well a patient will do, it's not just the myeloma that's the issue. You know, there are some patients, and there's a lot of research going into this aspect as well, which was presented at this ASH, looking at trying to find different scoring systems in a way to assess how fragile a particular patient is. So, you know, if someone has a lot of other health issues, including cardiac or kidney problems, diabetes, high blood pressure, versus someone who has really no past medical history, you know, that patient, those two patients, although they have the same condition, will do very differently over time. And the same thing, what I mean about within a particular patient, we know that multiple myeloma has different, what we call clones, so different faces. And so that, when you institute one treatment, you may be hitting upon the majority of your myeloma, but there might be another family within this myeloma that is a little bit resistant to that treatment. And so when someone is relapsing, it might be that different family that's coming forth. So all of this to say is that it's a very complex condition, and this is what accounts for all of the different outcomes that we see. So I'll jump into some of the clinical trials. I'll focus on the newly diagnosed first, and with the patients that are transplant eligible. And when we talk about treatment for transplant eligible patients, it really needs to be looked at in three parts. And so we look at it as in remission induction, so whereby you're receiving the treatment before the transplant to put you into remission. The transplant, which sometimes people consider something like consolidation, so it's to consolidate that good response that you've had with the first part of your treatment, and then finally maintenance. What's important about this study is it looks at the utility of what transplant is these days, because it is being questioned in the era where we have such great medications for multiple myeloma, such as the proteasome inhibitors like Velcade and the immunomodulatory agents such as Revlimid. The question as to whether or not do we need to subject people to transplant when perhaps we can get just as good outcomes with these newer medications now. And the long and the short of it is that it's still a very important tool for us. So there are many studies that are looking to delay or avoid transplant altogether, but there were two important studies that were reviewed at ASH. There's this one, which I'll go into in more details in just a moment, and there was another one out of France in collaboration with the Americans, which had a similar message, but I won't focus on it too much because it does use medications that are quite difficult to combine here in Canada. We could talk about the drug access in Canada as well, perhaps at the end. But I will focus on this one because it's closer to home. So the medications that are being used here, so in the remission induction part of it, is VCD, or what we call here in Canada called Cybord-D. So it's a slight variation of what we use, but it is the same medications that we use. And in this study, it's a big study, so over 1,000 patients received a combination of these three medications to get into remission. And at that point, they were randomized. So basically, that means half of the people were, without selecting, were randomized to receiving what we call consolidation with a Velcade, melphalan, and prednisone, or they were randomized to receiving a stem cell transplant. After that, they were randomized again to get either further consolidation therapy or none, and then everyone was put on lenalidomide maintenance, which we'll also be talking about a little bit later in this presentation. And so here we'll go into the results here. So the median follow-up, so again, the word median just means that 50% of people have achieved this duration of follow-up and 50% haven't. But the median follow-up for this study when it was presented was at 38 months. And the progression-free survival, oh, hold on, what happened to my definitions? Sorry about that. I think I may have skipped over a slide here. I just went back a little bit. So in terms of defining the acronyms that we use in these studies, there's the progression-free survival, which is essentially the moment that someone progresses or loses their remission from when they get randomized. Overall survival is the same type of thing, except that it pertains more to the death as opposed to losing remission. and then the response rates, which we kind of went over in the word median as well. Sorry, so I'll just jump back out here. So with the regards to the median progression-free survival, so in this study, it wasn't yet reached in the transplant arm compared to 44 months in the arm where the patients did not receive transplant. So as you can see, this was a statistically significant finding. At 3 years, basically 64% of patients who were who received the transplant were still in remission, compared to 57% who had not received the transplant. So it is still an important tool for us. And although this data went on further to suggest that perhaps you get the biggest bang for your buck with a transplant in terms of the duration of your first remission, there is an insinuation that it doesn't actually affect how long the patients live. So meaning that it didn't seem to have a big impact on the overall survival of patients, suggesting that perhaps the timing of transplant can be played with. So it's an important weapon in our armamentarium against myeloma, but there are some people that feel as though perhaps saving it for when a relapse occurs would give you the same duration of life. That being said, I say that with a lot of caution, because all of these studies that looked at trying to delay transplant, for example, in this study that we were just talking about, patients who ended up progressing in the arm where they didn't get transplanted received a transplant when they relapsed. But what was important in this study is that roughly 40% of patients who relapsed were not in good shape enough to undergo a transplant. Essentially, you lose that weapon, which is in your armamentarium against myeloma. So the general consensus in treating myeloma right now is to do the transplant up front after you get your first remission with the induction chemotherapy, because it gives you your best bang for your buck. The remission is the longest at the beginning, and also you're generally in your best shape when you're starting your therapies. And this was echoed in other presentations as well, and other studies, including that French-American study that I was referring to, whereby a lot of patients, when they relapsed, who were supposed to get a transplant at that moment, were not fit enough to do so. So this is an important study in confirming that in the era where we have a lot of new great medications for myeloma, autologous stem cell transplant still remains a very important tool. Of interest in this study, there are certain centers in Europe that preferentially do 2 transplants or tandem transplants. And that question also comes up a lot, is there a role for doing what we call tandem transplants, which means to do back-to-back autologous stem cell transplants, preferably within 3 to 6 months of each other. And so what this study showed is that in patients who received a tandem transplant, their progression-free survival was better, but that improvement in progression-free survival was primarily driven by the fact that it was the high-risk patients who benefited the most from this approach. So high risk in this study were defined by that staging system that I had mentioned, where they looked at the cytogenetics, and there's a very particular cytogenetics that are used to define what high risk is. And you can see that from this study, that although this is everybody over here, so the blue line is patients who had 2 transplants and the red line is 1 transplant, you can see that patients who have had 2 transplants seemingly do have a longer progression-free survival than patients who have had one transplant. However, when you look down at this slide, this part of the slide over here, these are the high-risk patients. And you can see that that benefit that you're seeing up here is primarily driven by these patients who are high risk. And so to receive 2 transplants, if you're a high-risk patient, it seems to improve your outcome quite a bit compared to if you've only received one. Managing high-risk myeloma patient remains one of our most difficult tasks as physicians, and so it is imperative that we use all of our best weapons as early as possible, and perhaps even more innovative strategies in clinical trials if they're accessible. And so I think this is a good study where they use medications that are quite similar to what we use in Canada, demonstrating that a tandem transplant approach for a high-risk patient could be quite beneficial and warrants a lot of discussion. I'll jump to maintenance here. So lenalidomide or Revlimid maintenance has concretely demonstrated an improvement in the progression-free survival after stem cell transplant in 3 very large trials. These 3 large trials have now been analyzed all together, and which is what essentially has convinced the myeloma community that giving lenalidomide maintenance after a stem cell transplant is probably what the standard of care should be. This is a study that was presented out of the UK, where they looked at transplant eligible and transplant non-eligible patients, and I'll show you in a moment that improvement in the progression-free survival applies to everyone across the board, including transplant non-eligible patients. So, sorry, just a moment. So these are sort of the outcomes. Hold on, I'll go back. I'm jumping the gun here. I don't want to lose time at the end. I'm sorry that we started a bit late. So this is the study where you have, it's a very large study, as you can see here with the numbers of over 4,000, but these are transplant and transplant non-eligible patients. It's quite a complex study, and so I'm not going to go through all of it, but this is the part over here that I'll focus on, which is essentially the maintenance part of it. So you could see here that after they've received their induction, there are some patients that got more therapy based on their response, and then there are some patients who got transplant, but ultimately they were all randomized to receiving maintenance lenalidomide, which in this study was given 10 milligrams per day for 21 days out of a 28-day cycle until progression of their disease. So the outcomes here demonstrate that you could see the median follow-up was 30.6 months. And you could see that in patients who were observed compared to patients who received the lenalidomide maintenance, receiving the maintenance really did improve the outcomes. So the dark blue here is all the patients. So these are all the patients on observation who their progression-free survival was 20 months. And these are all the patients who went through this whole algorithm and received lenalidomide maintenance, whose progression-free survival was 38.9 months. These are the bars in light blue and I suppose purple are basically whether you would receive transplant or not. So the light blue are the transplanted patients, and you can see that this benefit with the lenalidomide maintenance is really predominantly derived from the transplanted patients. So without lenalidomide maintenance, the transplanted patients were having a progression-free survival of 30 months. And with lenalidomide maintenance, that had jumped to 56.9 months. For patients who are not transplanted, the progression-free survival was in the realms of 11 months, and then with the maintenance up to 26 months. So you could see that all patients benefit from lenalidomide maintenance. And this was also sort of seen in this study. It was also seen across the high-risk groups as well. So this is an important study to explain to us that what we are doing with lenalidomide maintenance is confirmed as it was in all these other studies. And also in our non-transplanted patients, there is probably a role for giving lenalidomide maintenance. Now, we also know from other large clinical trials, there was a very large clinical trial that was presented last year called the FIRST study. Some of you may be akin to this one, where patients received lenalidomide and dexamethasone as their induction therapy. These are patients that were not eligible to transplant. And it seemed as though continuing this therapy until progression of their disease was what provided the longest duration of progression-free survival in the non-transplant patients. So we're already getting the sense that sort of continuous therapy is what provides probably the longest duration of remission. Now, we always have to take that into account to balance what these therapies are doing in terms of, are they having a terrible side effect profile? So all of this need to be balanced out, because ideally we'd like to keep people on therapy based on all these results we're seeing, but certainly not at the cost of quality of life. And so all of these things need to be taken into consideration. Now, the duration of maintenance therapy remains a big question amongst the myeloma community. And the reason being, although, like I had just mentioned, continuing it until progression seems to provide the longest duration of progression-free, the longest duration of remission, there are some important signals that have come about with ongoing lenalidomide maintenance. And probably the one that is most spoken about is the risk of second primary malignancies. And so that means that there seems to be a small signal where patients who are on lenalidomide maintenance are at a slightly higher risk of developing other malignancies. Now, this risk, the percentage is very, very low, in the realms of 3 to 4%. And so it is kind of more of it's a lesser issue compared to the myeloma in the grand scheme of things, but it's certainly something that is worth a discussion with your hematologist if ever there are concerns about this thing. And what this slide is showing here is that, so what it's trying to show here is that the blue line here is essentially what so the dark blue line that is on top over here and over here is basically the myeloma that is what eventually overcomes the patient, compared to these lower lines here. One of them is the pink one is the death related from other cancers, and the light blue one is death just in general, not related to myeloma. So you can see here that this dark bar up here, which is the myeloma, as is really the wolf barking at the door, as being the main issue that patients are losing their lives. And so again, in a big proportion of the myeloma community right now, the feeling is continuing until progressive disease to optimize the duration of your remission is probably what would be the most useful. However, it is something to discuss with your physician if you need more clarity on that. So, like I said, we now have several large trials and a meta-analysis, which basically combines the three trials, clearly demonstrating essentially doubling the duration of remission after a transplant. From a practical standpoint, a real-life standpoint, it's not always the easiest to get the recommended dosing of lenalidomide maintenance as they did in the study. And the primary reasons for that are, low blood counts, certain side effects such as fatigue that may arise. This is a small poster presentation from ASH, which I particularly liked because it was very applicable. It was very, it spoke to our real life experience, not to mention that it is Canadian. It does come from the Princess Margaret Cancer Center. And so again, we all tend to have very similar practices as Canadians. And so what this poster is showing is that, in fact, we may not need to be as aggressive as they were in these clinical trials to obtain the same or similar results. What we're looking at here is that this is the sort of the dose delivery in terms of percentage of what you're supposed to have. So for example, if having 10 milligrams a day every day is 100%, you can see here that over time, patients were receiving 80% of the dose and so on and so forth. And you could see that the reason for why that was happening was because to improve quality of life. We can't forget what the goals of therapy are here. So when we're talking about maintenance, we're talking about giving you a medication to keep you in remission for longer. We're not talking about trying to pummel you with treatment like we were at the very beginning when the disease is very active, when it's the most life-threatening. We aren't as, I would say, accommodating because we want to try to get control. Here, it's a very different situation. Here, you are already in remission, and now we're just trying to maintain that remission. So it doesn't make very much sense to us to give you a medication that's going to make you feel unwell just to make the remission longer. I mean, the purpose is, yes, to make you live longer, but also to make sure you're having a good quality of life. And so what this study showed is that even with significant dose reductions sometimes, there did not appear to be a detriment on the duration of that remission. So in this study where they looked at just over 100 patients, the progression-free survival was in the realm of 42 months, which is quite similar to what we were seeing in these bigger studies. And so this is very reassuring because I think it confirms and makes us feel better that to dose reduce and make sure that you can tolerate the therapy well with fewer interruptions, but perhaps on a lower dose, in fact, may be better than frequent interruptions because of side effects and trying to pummel some of that higher doses in. So this was just a poster that I thought spoke to us and how we practice, and confirms that in fact we are not doing any harm in lowering the dose and making sure that it could be better tolerated. I'll switch to so the non-transplant eligible patients. So transplant non-eligible patients in the newly diagnosed setting. This was what they called a late-breaking abstract, so a very important study. And this study builds upon a backbone that was published roughly 10 years ago now from a trial called the VISTA trial, where it combines the Velcade backbone with, which was combined in this study with melphalan and prednisone, and adds Daratumumab. So Daratumumab, I would say, is a medication that's creating quite a splash in the myeloma community. It's quite exciting, and it's a new molecule. What's nice is that it's a different class of medications altogether. So right now, when we talk about Velcade and carfilzomib or Revlimid, lenalidomide, and pomalidomide, these are all very good medications, but belong to two classes, which are the proteasome inhibitors and immunomodulatory agents, respectively. So what's nice about Daratumumab is that it's a completely different family of medications in the world of what we call monoclonal antibodies, and so it would fit quite nicely in combination with a lot of our medications. And so in this study, they added it to Velcade, melphalan, and prednisone in newly diagnosed transplant and ineligible patients. So here's the study design. So it's all a big study. 700 patients were randomized to receiving either the classic Velcade, melphalan, prednisone, or Velcade, melphalan, and prednisone associated with Daratumumab, after which, for 9 cycles each, after which the Daratumumab was continued in the arm for the patients who received it in induction until progressive disease every month as a sort of ongoing maintenance therapy. So as you can see here, there was a marked benefit with the addition of Daratumumab as expected, and you could see that at 18 months, so the median follow-up was 16.5 months, but at 18 months, the progression-free survival for patients who received the Daratumumab in association with their chemotherapy was 72%, and whereas it was 50%. So about half the patients had progressed on the VMP arm at 18 months. compared to 72%, which were still in remission if they had received the daratumumab. In terms of the efficacy, so you could see that the response rates are much higher if you've received the daratumumab, so 91% overall response rate compared to 74%. And when we were talking about those depths of responses, that's what we are seeing here. So patients who received the daratumumab, 71% of them had at least a very good partial response, or better, so either a complete response or a stringent complete response. And compared to if you only received the VMP, your overall response rates were 74%. And what you can see on this side over here is what we were speaking about before, which is minimal residual disease. So the two upper curves here are patients who were minimal residual disease or MRD negative, and you can see that the red line is the VMP arm, and the yellow line is the Dara VMP line. And you could see that if you were minimal residual disease negative, you did very well. Your progression-free survival is very high. And so if you remember what I said at the very beginning, it's not necessarily how you get to that minimal residual disease state, but it's achieving it, which seems to be the important predictor of how well you're going to do. Now, that being said, here it looks like these curves are overlapping, but if you look at the details, or the devil is in the details, so you can see that in the Dara VMP arm, there were many more patients who achieved MRD negativity compared to the VMP arm. So it's 78 versus 22. So you can see that achieving MRD negativity seems to be very important and predictive of how long the remission will be, and that however you get there, it doesn't really matter. If you get there, you're doing well. But certainly, with the addition of daratumumab in this study, more patients were able to achieve that negative state. And in patients who were in a good response but were still MRD positive, you could see that the benefit of adding daratumumab was still there, as you can see with these two curves. Now, daratumumab is a medication that is overall quite safe. In some of the earlier studies, the biggest concern had to do with infusion reactions. However, in this study, where now we've had a lot more experience with daratumumab, the infusion reactions were certainly not as hyped in this trial. We're more cognizant of them, we're more ready to manage them, and so whereas more than half the patients used to have these infusion reactions, in this study about 28% of patients had them, and they were primarily low-grade reactions, and they were predominantly at the very beginning, after which they did not occur again. And the main safety issue in this study was that there were slightly higher respiratory infections in the patients who received the daratumumab. So that's something to keep in mind and be vigilant about infectious type symptoms. Now, the daratumumab, as I mentioned, is a very exciting medication. This is sort of the first presented phase 3 study in newly diagnosed patients. However, we're anxiously awaiting other combinations such as daratumumab combined with lenalidomide and dexamethasone, as there seems to be a synergy between lenalidomide and daratumumab that is more pronounced than Velcade and daratumumab. So we're anxiously awaiting those studies, and there are also other upfront studies, including lenalidomide backbones with oral proteasome inhibitors, which is quite an attractive option, as it provides a purely oral regimen for some patients who, trekking back and forth to hospital could be a big issue. So we're waiting for all these results, and some of them, for example, the ixazomib, Revlimid, dexamethasone study called the Tourmaline 2 study is going to be presented this year at the European Hematologic Association meeting. So we're having more and more of these studies that are coming out and changing sort of the landscape of multiple myeloma. I'll jump to a relapsed myeloma or refractory myeloma, and the two big studies that were updated were Pollux and the Castor studies. And so the Pollux study looked at, so these are patients who have relapsed after either one line of therapy or more. And you could see here that patients were randomized to either receiving lenalidomide and dexamethasone, which is essentially the standard of care in many countries, or receiving lenalidomide and dexamethasone in combination of daratumumab. So again, daratumumab initially has been working its way to the front line there, but up until now, most of the published studies are in relapsed myeloma. This study looked at randomizing patients to receiving lenalidomide and dexamethasone versus daratumumab, lenalidomide and dexamethasone. And you could see that this was updated at ASH with now a median follow-up of essentially 33 months. And you could see that the 30-month progression-free survival for patients who had received daratumumab, lenalidomide, and dexamethasone is 58%. So that's quite, for when we talk about relapsed myeloma, this is probably one of the longest remissions that we can get in the relapse setting. Most of the time, the longest duration of remission is upfront, so that's why we go big upfront. We try to give our good weapons upfront, because the natural history of multiple myeloma is such that the remissions tend to be the longest at the beginning, and then unfortunately with each relapse they tend to get slightly shorter. And so the consideration of this being a relapse study, to have more than 50% of your patients at 30 months still be in remission in the relapse setting is quite a powerful. This is quite a powerful regimen that we're hoping to be able to access. So this is again the efficacy, showing that the overall response rates are 93% versus 76%. And again, this is the minimal residual disease assessments that I was referring to, whereby we're getting much more MRD negativity with the addition of this new compound. So this is the other big phase 3 relapse study where daratumumab was combined with Velcade and dexamethasone. So similar concept, except a different backbone. So in this study, rather than receiving lenalidomide, patients received Velcade and dexamethasone in combination with daratumumab or alone. And again, so not to belabor the point, but the addition of this medication did improve outcomes quite significantly. That being said, this is what I was referring to earlier. It seems like daratumumab's potential is definitely increased when it's combined with lenalidomide. So although you're seeing an improvement here with the addition of daratumumab, it's certainly not as pronounced in this study as it was in the Pollux study. And so I believe that combining the monoclonal antibodies such as daratumumab with the immunomodulatory family, so Revlimid, pomalidomide, I think that's where most of the money is going to come out of in terms of the best bang out of your therapy. So I think we only have about 10 minutes left, and I do want to leave some time for questions. I'm going to quickly touch upon sort of new exciting targets that are being looked into. So this is predominantly in the clinical trial settings. So BCMA, or the B-cell maturation antigen, is a new target on plasma cells that is seemingly appearing to be extremely exciting as a target that we'd like to drug with certain new medications. So there was a phase 2 study that was presented by Dr. Suzanne Trudel, again, so Canadian representation. She's from the Princess Margaret and a good friend of mine. And so she presented on a monoclonal antibody targeting this antigen, so this protein that sits on the plasma cells. And so it's it's a protein, so it's a monoclonal antibody. So basically, it sticks to these antigens on the plasma cells and delivers a drug that it's combined to. And in the study that Dr. Trudell presented, that drug was called well, it doesn't really have much of a name, but it's a particular chemotherapy. So it basically delivers a strong chemotherapy specifically to the plasma cells, because these plasma cells are what express this protein on the cell surface. And what we saw is that in patients that were very, very heavily pretreated, so have had multiple lines of therapy before, and who essentially had progressed on all of our major drugs, the overall response rate was in the realm of 60%. So this was proving to be a very good medication, targeting a very good target on the plasma cells. The main side effects from this, though, so with every new drug that we discover, certainly we have to be ready to deal with new side effect profiles. And in this study, the biggest side effect had to do with the eyes and blurry vision and dry eyes, and most often they were reversible when you stop the medication, but certainly it's something that we're not usually used to seeing with a lot of our myeloma treatments. But that being said, it's a completely new mechanism of action and seems to be overall well tolerated, and so we're looking to develop that and open up a clinical trial through the Myeloma Canada Research Network to target this receptor. Sorry, I don't know what happened. It just kind of, I'll just go back to where we were. And so that brings us to CAR T cells. So CAR T cells, it stands for chimeric antigen receptor cells, T cells. So T cells are part of are a subset of white blood cells that we have within us. And so essentially what this technology does is that it takes the patient's own lymphocytes, T lymphocytes, and engineers them using a virus to express sort of receptors to attack different proteins on the cancer cells. So this is being used really widely now in other cancers, and it's proving to be very, very beneficial in acute leukemia, specifically ALL, and acute lymphoblastic leukemia. And now we're starting to see some data in the world of multiple myeloma that appears to be quite promising, but we do have to keep in mind that the follow-ups for these studies are extremely short. So we don't seem to really have much more follow-up beyond 9 to 12 months. And so the durability of these regimens, which have a very particular toxicity profile. In a way, you need to be conditioned such as like essentially like a stem cell transplant in order to be able to receive the infusion of these cells. So there's quite a bit of a toxicity profile that comes along with it, but certainly in the preliminary studies where these cells are engineered to attack different targets, and specifically this BCMA target that we just spoke about, the results do seem quite promising in these heavily pretreated patients. So there's definitely more to come from and to hear about when it comes to these CAR T cells. And just briefly, in terms of immunotherapies in myeloma, I mean, a lot of you may have heard that there are these class of medications called the PD-1 inhibitors, which are medications that sort of activate the immune system. A lot of these studies have been put on hold in multiple myeloma when they've been combined with the immunomodulatory medications such as lenalidomide or pomalidomide. It seems that there was an excess in toxicities when the two were combined. So perhaps it doesn't mean necessarily that it's not going to work for myeloma, but perhaps it's a signal that the combination might be too potent and it does need to be looked at in closer details. So for now, a lot of those studies have been put on hold. So with that, it was really a whirlwind tour. I wanted to sort of set the ground at the beginning, try to get the lingo going. I'm sorry if a lot of this was technical. but it's hard to not be technical these days in myeloma, because the number of studies that are being published and the number of medications that are being developed in the world of myeloma it's exploding. It really is. And when I have to compare it to other malignancies that I treat, it really seems to be a field that's booming. And so I guess the ultimate message that needs to come across here is not so much all these numbers I just quoted, but perhaps that the myeloma landscape is changing dramatically. It's changing relatively quickly. And so you need to take each line of therapy one step at a time, dive right into it, and you never know what will come about in the upcoming years. While you're in a remission, that you might hear of a new medication that's being approved. And certainly, it's always good to keep your ears and eyes out for clinical trial opportunities, because clinical trials are important not only to understand and develop new medications, but in a system like ours in Canada, where a public system exists, it also allows us to get access to a lot of these great drugs that are already well studied that we don't necessarily have the ability to access at this point in time due to sort of an economic burden on society. So I'll leave it at that. So that way, Gabriele, maybe if there's a few minutes for questions, I'd be happy to answer.
Thanks, Dr. Kaedbey. That was an excellent presentation, very informative. So we do already have quite a few questions. So I guess I'll start with the first one. So,
okay.
Do you know of any clinical studies which are not meta-analysis that show overall survival, not PFS, is improved with maintenance therapy?
So that's a very good question, and that's part of a lot of the debate about how long it should be continued or not. But so you're right in excluding the meta-analysis, because the meta-analysis did demonstrate the survival advantage. And so the maintenance study that did demonstrate survival benefit was the CALGB study. So it was the American study published by McCarthy. That one, in addition to showing the progression-free survival, it did demonstrate an overall survival benefit as well. So there was a lot of kerfuffle about why did that study demonstrate an overall survival compared to the French study, which was initially published. Why did that, which did not demonstrate a survival benefit? So you do have to remember that the two studies were done somewhat differently, with one study where patients received consolidation, another where they didn't. In one study they received, in the American study that showed the survival benefit, the patients received it until progressive disease. In the French study, they received it for a fixed duration, which was 2 years. So there are slight differences there, but that is the one study that demonstrated, outside of the meta-analysis, a survival benefit.
Okay, thank you. So we have another question. A friend of mine that's in the US is currently undergoing CAR T cell therapy through the trial. Do you know if there are any CAR T cell trials for myeloma currently taking place in Canada, or are planned to take place in the near future?
So we are working really, really hard to get the Myeloma Canada Research Network involved with a lot of these CAR T cell trials. To my knowledge, it could be quite close. If there's a center that's going to open first, it'll probably be the Princess Margaret Cancer Center. I think they may be getting close to opening one, but at this point in time, there isn't one that's officially open.
Okay, thank you. So has lenalidomide been used instead of cyclophosphamide in induction chemo pre-stem cell harvesting?
So lenalidomide. Right now in Canada, we aren't really using lenalidomide pre-transplant unless the Velcade cyclophosphamide dexamethasone combo isn't working very well, at which point we can access lenalidomide and dexamethasone and use it at that point in time. In the US, they are using Velcade in combination with lenalidomide and dexamethasone as an upfront therapy, which seems to provide deeper responses, but has not really ever translated into more meaningful progression-free survival. So in a way, although we feel as though we want to get the three combination, those three drugs together, the Velcade, lenalidomide, and dexamethasone, because it harps on the biggest classes of medications that we have, at least we feel as though in terms of the general survival, progression-free and overall survival, they seem to be doing just as well. Now, the thing that you need to know about, if you do receive lenalidomide before a transplant, you need to make sure that your stem cells get collected within the first 4 cycles, I would say, because lenalidomide has demonstrated toxicity against, or I would say, you know, people have a harder time getting their stem cells collected if they've received a lot of lenalidomide before that part of their treatment. So it is something that if you are using an induction before transplant, you need to make sure you get your stem cells collected within the first 4 cycles.
Okay, fantastic. So one more is I'm wondering what the current research shows for the genetic link with myeloma, specifically with siblings and children of those diagnosed with myeloma. Are there specific recommendations for testing protocols for those with potential genetic links?
So that's a very good question. I mean, as a general rule, myeloma is not a genetic disease. There doesn't seem to be a pattern of inheritance that we can pick up on, or a particular gene that has been demonstrated that if it's mutated, you will receive myeloma, kind of like in the breast cancer world. That being said, there is a higher incidence of myeloma in first-degree relatives of a patient who have had it. So are there general recommendations? Not quite. What I always tell my patients is just that, you know, when you are seeing your physician, to mention your family history, because certainly, you know, unfortunately, myeloma sort of flies under the radar a lot of the times, but certainly if someone has an anemia, for example, which can be caused by so many things, if I were to know that this patient had a first-degree relative of myeloma, I would certainly send off the screening tests and to look for those proteins much earlier in sort of the algorithm, because a lot of family doctors kind of leave that you know, electrophoresis, the immunoglobulins, those sort of checks until other types of workup have happened. But certainly if you know that there's been a first-degree relative, it may expedite things a little bit.
Okay, great. Thank you for that, Dr. Kaedbey. So another question here. No, that's not an appropriate question for this webinar. So are there trials of selinexor in Canada?
Yes, yes, certainly there are. So Canada has a lot of experience with selinexor, and we are all pretty comfortable with prescribing it. It does have a particular side effect profile that can sometimes be a little bit difficult to manage, particularly with the GI, the gastrointestinal type of toxicities, for example, nausea and anorexia and stuff like that. And it also can lower your platelets. But there are clinical trials that are opened in combination with Velcade. I think there used to be one in combination with lenalidomide, with an immunomodulatory, but I'm not sure if that one is still open. But there is one trial called the Boston trial, which is still currently open.
Thank you. Well, so I do have a few more questions here, but we're running late, and it's I don't want to take the time of too many. If you don't mind, Dr. Kaedbey, I can send you a few of these questions, perhaps by email, and I can provide some responses.
Sure, I would be happy to.
Okay, great. So I'll be in touch, and thanks again for taking the time from your busy schedule on a Thursday evening to do this webinar and to inform.
It's my pleasure, and like I said at the beginning, you know, just keep throwing yourselves into this sort of environment. Try to grasp as much of it as possible, and be very engaged in your care.
Yeah. So thanks again, and have a great evening. And just a reminder to everyone, this session was recorded, and it will be available on our YouTube channel, hopefully within the next day or two. So thanks again, and have a great evening.
All right. Take care.
Bye-bye.